In this lecture video, I will discuss about approach to neuropathy, plexopathies and radiculopathies. After completing this lecture, you will be able to categorize neuropathies. You will be an expert at drawing the brachial plexus in a 6 simple steps and able to recognize the common plexopathies and develop an understanding of common pattern of cervical and lumbosacral radiculopathies. Along the way, we will discuss about diabetic neuropathies, heavy metal associated neuropathies, nutritional neuropathies, inflammatory polyradiculoneuropathies, vasculitic neuropathies, brachial plexopathies, and lumbosacral and cervical structural radiculopathies. So, we will discuss these neuropathies with a clinical case and try to understand the pattern that are present in these neuropathies and how we can differentiate these neuropathies. In polyneuropathies, we will discuss about the pattern in relations to what is the lesions, where is the lesions, when has this lesion occurred, and in what context these lesions has occurred. That is, whether the lesions, that is polyneuropathies, has occurred in relation to infections, in relations to any autoimmune disorders, in relation to any pressures effect. We will discuss these polyneuropathies in these headings. Let us discuss a hypothetical case. A 65-year-old woman who presented with years of tingling and numbness in his both feet. He appreciates no weakness, back pain, or radicular symptoms. On review of systemic examinations, he noted postprandial bloating and occasional constipation. He does not drink alcohols and takes no medications. On examination, he is mildly overweight. Sensory examination shows light touch is felt less and causes tingling below the ankle. Vibration sensation and temperature sensation are reduced in all toes. Toe extension is mildly weak and ankle dip tendon reflex is absent bilaterally. So, what is your diagnosis with these history and physical examinations? It is a case of diabetic polyneuropathy. How? Let us discuss that. So, in this case, what is the lesions? So, this patient has sensory symptoms, motor, along with autonomic symptoms in the form of constipation and bloatings. This is acute, subacute or chronic presentations, and this is a symmetrical, or whether it is asymmetrical, length dependent or diffused lesions. Or is there any illness, exposure to toxins, medications, or any social or family history relevant in this case? So, these are the 3 common patterns in polyneuropathies. First one is symmetrical, length dependent polyneuropathies with sensory symptoms more prominent than motor symptoms. Second one is symmetrical, diffused polyneuropathies with motor symptoms more prominent than sensory symptoms. And third one is asymmetrical or multifocal neuropathies with sensory and motor symptoms more or less has equal, the patient has more or less equal sensory and motor symptoms. We have the three common presentations. So, if the patient has symmetrical length dependent polyneuropathies with sensory more than motor symptoms, then what is your common DDs in this case? With these presentation, the common DDs include diabetes, vitamin deficiencies with B1, vitamin B12 or vitamin E deficiencies, alcohol toxicities, paraproteinemia related neuropathies, amyloidosis, vasculitis or idiopathic. So, if the patient has symmetrical length dependent polyneuropathies, these are the common etiologies that can be seen in the patient. So, neuropathies with prominent dysautonomia. In these cases, the common symptoms and signs that the patient can present include tachycardia, orthostatic hypotension or fatigue, gastrointestinal symptoms in the form of early satiety, constipation or diarrhea, genitourinary symptoms in the form of sexual dysfunction, urinary urgency, hesitancy, incontinence or recurrent UTI, thermoregulatory defects, cutaneous manifestation in the form of molting or discolorations, visual symptoms in the form of blurred visions or impaired night vision. So, these can be the common presentations with the neuropathies having prominent autonomic symptoms or having dysautonomia. The causes for it include diabetes, acute inflammatory demyelinating polyneuropathies, amyloidosis, hereditary sensory autonomic neuropathies, porphyria, HIV associated neuropathies and idiopathic. So, these are the common neuropathies along with sensory symptoms more prominent than autonomic symptoms. Along with the neuropathic presentations, these patients also present with autonomic dysfunctions. So, this was all about neuropathies with prominent autonomic dysfunctions. So, this was a case of diabetic polyneuropathies. And this patient has sensory and motor symptoms, more prominent being the sensory symptoms. The patient has chronic presentations with symmetrical and length dependent neuropathies with the recurrent other manifestation include overweight. Apart from it, the patient is not alcoholic or on other medications, or that is the concurrent illness. So, this was a case of diabetic polyneuropathies. So, these are symmetrical length dependent sensory polyneuropathies. Now, let us talk about diabetic neuropathies. These diabetic neuropathies are length dependent, symmetrical, sensory, more than motor neuropathies, with focal neuropathies can also occur in it, which include the involvement of cranial nerve third or sixth, thoracic radiculitis with sensory and motor weaknesses or diabetic amyotrophy. These are the different diabetic neuropathic presentations that can be seen in the patients. Heavy metal intoxications are not routinely tested in distal sensory neuropathies, and presentation often consistent with the presentation of chronic sensory neuropathies in heavy metal associated neuropathies. These are the common heavy metals intoxications that can lead to neuropathies. First one is lead, mercury, arsenic, thallium, and gold. So these are the common metals that can lead to neuropathies. Lead lead to non-length dependent, more prominent motor manifestations, whereas mercury lead to motor neuropathies. Other associated presentation include encephalitis or psychosis that can be also be seen along with neuropathies in mercury associated intoxications. Arsenic associated neuropathies will present with symmetrical sensory more than motor neuropathies, and hyperkeratosis is because of arsenic intoxications, that is depositions of arsenic on the skins. Thallium will lead to length dependent painful sensory more than motor neuropathies. Other manifestations include Milan or alopecia. Gold will lead to painful neuropathies or GVS-like peripheral neuropathies. It is also associated with encephalitis. So these are the common heavy metals that can be associated with neuropathies, and these are the different patterns that are associated with these heavy metals poisoning intoxications. That is when to consider the nutritional neuropathies. We can consider the nutritional neuropathies in alcohol abuse, dietary malnutrition, comorbidities causing malabsorptions like bariatric surgery, inflammatory bowel disease, or cystic fibrosis, or medications that include isoniazid and hydralazines. So, in these cases, nutritional neuropathies can be presentations in the patient. The vitamins that can lead to neuropathies include thiamine, pyridoxine deficiency, pyridoxine excess, cobalamin, copper, and vitamin E. These are the common vitamins that can be associated with neuropathies. Thiamine will lead to diffused motor or sensory motor polyneuropathies, GVS-like. Other associated manifestations of thiamine include Wernicke's encephalopathy and heart failure with very thiamine deficiencies. Pyridoxine deficiency will lead to length-dependent sensory polyneuropathies with the presentation of numbness, pain, and paresthesia. These patients can also present with seizures, along with medications that include penicillamine and isoniazides that can lead to pyridoxine deficiency. Pyridoxine excess will lead to sensory ganglionopathies. These patients will present with numbness, pain, and paresthesia along with areflexia. Cobalamin deficiency will lead to sensory polyneuropathies or myeloneuropathies, optic neuropathies, and neuropsychiatric features. These patients will present with pernicious anemia, and nitric oxide supplements exposures can lead to cobalamin deficiencies. Then copper deficiency will lead to myelopathies or myeloneuropathies or motor neuron-like disease presentations. Zinc excess and bariatric surgery can lead to copper deficiency leading to neuropathies. Vitamin E deficiency will lead to sensory polyneuropathies more than myelopathies. This patient will present with numbness, ataxia, or hyporeflexia. This vitamin E deficiency is more common with fat malabsorption, page caries, scoliosis, dysarthria, and ophthalmoplegia. So, These are the common patterns of vitamins deficiency leading to neuropathies, and these are the different associated features that can be associated with these vitamin deficiency. And let us again discuss another clinical case. This 28-year-old man presented with 3 days of uncomfortable tingling in his hands and feet and 1 day of severe back pain, difficulty in climbing stairs, and difficulty gripping his toothbrush. He reported a brief upper respiratory illness approximately 2 weeks ago. On examination, he is afebrile with blood pressure of 124/78, heart rate of 121 beats per minute, respiratory rate of 15, SpO2 of 99% on room air. He has tactile paresthesia in his hands and feet. Motor examination shows mild symmetrical distal and proximal weakness in all 4 limbs. He is areflexic in arms and legs. So, with these presentations, what is your diagnosis with the physical findings and examinations? So, it is a case of acute inflammatory demyelinating polyneuropathies. How? In this case, first one is what is the lesions? What is the presentation in our patient? It has motor, sensory, and autonomic manifestations. It is an acute presentations, and it is a symmetrical and diffused presentations with recurrent illness 2 weeks ago. So, our patient has symmetrical diffused polyneuropathies with motor more than sensory presentations, and the DDs for it include AIDP or GBS, CIDP, osteosclerotic myeloma, that is Poems syndrome, drug toxicity like amiodarone, hereditary like Charcot's-Marie-Tooth disease. So these are the DDs that can be seen in this patient. So this was a case of acute inflammatory demyelinating polyneuropathies because there is no history of drug intoxications, there is no family history in it, and there is no such myeloma proteins given in our case. So it has acute presentation, CIDP is ruled out, so this is a case of AIDP or GBS. Then acute inflammatory demyelinating polyneuropathies, that is AIDP or Guillain-Barré syndrome, is characterized by rapidly progressive symmetrical proximal and distal, that is diffused weakness with tingling and numbness in the hand, feet and face, milder than the weakness. Respiratory weakness in up to 1/3 of the cases can occur with the progress of the disease, autonomic instability and low back pain. So these are the different clinical manifestations that a patient of GBS can present. Pathophysiology include, it is a T-cell mediated autoimmunity disorders. Pathologies with perivascular mononuclear infiltrates and multifocal demyelinations can occur. And in 2/3 of the cases, it is associated with para-infections, most commonly Campylobacterium jejuni, Epstein virus, HIV and Mycoplasma. Molecular mimicry being another pathophysiology that can lead to AIDP. What is this molecular mimicry? Our body forms an antibody for these pathogens, antigens for these pathogens. Our body forms the antibody for it, and this antibody reacts with our body tissues, leading to the manifestations of the disease. Let us discuss another clinical case to understand another neuropathies. A 28-year-old man presented with 3 days of tingling in his hands and feet with severe back pain and difficulty climbing stairs and difficulty gripping his toothbrush. He reported a brief upper respiratory illness approx 2 weeks ago. Acute inflammatory demyelinating polyneuropathy or AIDP or GBS was suspected. So, what is the additional test must be pursued prior to initiations of the treatment? Whether you will do MRI, whether you will do lumbar puncture and CSF before initiating the treatment, whether you will do EMG or nerve conduction studies, whether you will order for serum ganglioside antibodies or you will do none of the above before starting the treatment. So, what will be your next step before you start a treatment for this patient? So, you will do nothing before starting a treatment because GBS or AIDP is a clinical diagnosis. So, it is a clinical diagnosis, but on nerve conduction study, it is normal in early phase, but as the disease progresses, you can get a prolonged F waves, minimal latency, temporal dispersion or conduction blocks. CSF analysis will show albuminocytological dissociation with elevated protein or normal cell count in 50% at the first week and 75% at the second week. We can get these albuminocytological dissociation in AIDP or GBS. Treatment include respiratory monitoring with forced vital capacity of less than 20 ml per kg or negative inspiratory force of less than 30 centimeter of H2. We can order for the intubations because it can these are the common indications in which respiratory distress can be seen, and we can look for the respiratory supports in that very patient. First line of treatment include intravenous immunoglobulin in a dose of 2 gram per kg in 2 to 5 divided dose, and second one is plasmapheresis in 2 to 4 sessions depending upon the severity of the illness. Corticosteroids is not usually recommended. It is not the guideline in treatment of AIDP or GBS. Then different variants of AIDP include AMAN, that is acute motor axonal neuropathies, then acute motor sensory axonal neuropathies, AMSAN, then third one is Miller-Fisher syndrome, and then pharyngeocervical brachial variant. These are the common AIDP variants. Apart from it, we can have polyneuritis cranialis as the other presentations that can be seen. In AMAN, that is acute motor axonal neuropathies, it is similar to AIDP but no sensory involvement. And in NCB, we can get an axonal electrophysiology. That is axonal, not the demyelinating patterns of NCB. That is prolonged F-wave latencies, this temporal dispersions, conduction blocks. These are common manifestations. These are the manifestations of demyelinating neuropathies in NCB. It is mostly associated with Campylobacterium jejuni, and in serum we can get serum gangliosides GM1, ganglioside GD1A antibodies that can be looked for. In AMSAN, it is severe form of AMAN with sensory involvement, and in NCB we will get a axonal electrophysiology. In Miller-Fisher syndrome, It is characterized by triads of ophthalmoplegia, ataxia and areflexia. It is associated with antibodies like GQ1B and concurrent Campylobacterium jejuni infections is associated with Miller-Fisher syndrome. Then pharyngeal cervical brachial variant, it is characterized by weakness of oropharyngeal that will lead to dysphagia, neck weakness with head drops and shoulder weakness with or without ophthalmoplegia and facial weakness can be reported. The antibody that can be looked for in the serum if we are suspecting pharyngeocervical brachial variant is the ganglioside GT1A and ganglioside GT1B antibodies. These are positive in pharyngeal cervical brachial variants of CIDP. Then different variants of CIDP include chronic inflammatory demyelinating polyneuropathies, that is CIDP. Then MADSAM, that is multifocal acquired demyelinating sensory and motor neuropathies. Then multifocal motor neuropathies. Then distal acquired demyelinating sensory neuropathies. These are the common CIDP variants. CIDP and its variant. CIDP will present with clinical manifestation of gradual progressions of symptoms over more than 8 weeks with mild autonomic symptoms, and vulvar involvement is seen in 10 to 20% of the cases. Treatment include corticosteroids, IVIG, plasmapheresis, azathioprine, cyclosporin and cyclophosphamide. 90% of the improvements occur with therapy. Whereas MADSAM, that is multifocal acquired demyelinating sensory and motor neuropathies, will have multifocal asymmetrical involvement, and multifocal motor neuropathies will have multifocal motor weakness with cramps, fasciculations, arm weakness more than leg weakness with no sensory loss. Antibodies mostly positive in MMN include ganglioside GM1 antibodies, and it responds to IVIG. Whereas the distal acquired demyelinating sensory neuropathies are length dependent, sensory loss and areflexia with or without ataxia. It is associated with IgM monoclonal antibodies, and these are more resistant to therapies. So these are the common variants of CIDP, that is MADSAM, MMN and DATS, and these are the common manifestations that can be seen in these diseases. Let us discuss another clinical case to understand another neuropathies. This 65-year-old woman who developed numbness in his right foot over next 2 weeks, he noted severe burning pain over the dorsum of both foot. 1 week later, she developed severe lancinating pain in the left foot as well as left foot drop. 1 week after that, she developed numbness in his digit 4 and 5th of the left hand, promoting presentation to a neurologist clinic. With this presentation, he visited a neurologist. She reported a fatigue due to severe poor sleeps because of pain, weight loss because of difficulty cooking due to hand weakness, and there was no skin lesions, joint pain or fever. There was marked weakness of left finger abductions and adductions, milder weakness of left thumb abduction and distal flexions, and mild weakness of left ankle dorsiflexions and foot eversions. Strength is otherwise full. Sensation is reduced to pain in the medial left palm and fingers over dorsum of both foots and in soles of the left foot. So, with these presentations, what is your diagnosis? This patient developed numbness in his right foot. So, what is your diagnosis? Whether it's a diabetic amyotrophy, multifocal motor neuropathies, Lyme's polyradiculopathies, hereditary neuropathy liable to pressure palsy, or vasculitic neuropathies. So, this is a case of vasculitic neuropathies. In this case, the patient has sensory and motor symptoms. It is a subacute presentations and it is asymmetrical and multifocal presentations with weight loss, fatigues being the other concurrent illness associated with the neuropathies. So, here this patient has symmetrical, asymmetrical, multifocal neuropathy with sensory and motor symptoms being more or less the patient has equal sensory and motor symptoms. So, the patient fits into this criteria, this diagram, and so this is a case of these are the common DDs that is associated with asymmetrical or multifocal neuropathies. These include vasculitic neuropathies, diabetic amyotrophy, neuralgic amyotrophy, sarcoidosis, CIDP variants, neuroborreliosis, HIV associated CMV, leprosy, herpes zoster infections, amyloidosis, infiltrative lymphoma, or hereditary, that is hereditary neuropathies liable to pressure palsy. These all can lead to asymmetric or multifocal neuropathies. So, these vasculitic neuropathies will have multifocal mononeuropathies, acute or subacute onset, a stepwise progressions in 70% of the cases and progressive in 30%. It is a painful neuropathies and early sensory and motor deficits are prominent in these vasculitic neuropathies. Later stage include confluent neuropathies. So, these are the common presentation of vasculitic neuropathies. These vasculitic neuropathies can be primary vasculitis or secondary vasculitis. Secondary vasculitis include connective tissue disorders like rheumatoid arthritis, SLE, Sjogren's syndrome, systemic sclerosis, dermatomyositis, sarcoidosis, Behçet syndrome, infections like hepatitis B, C, HIV, paraneoplastic like a small cells, lung carcinoma or drugs. Non-systemic vasculitis include idiopathic or DRLPN or other diabetes. Distal, these are the other that can also lead to vasculitis. So, common primary vasculitic neuropathies include microscopic polyangiitis, eosinophilic granulomatosis with polyaginitis, that is Creutzfeldt-Strauss syndrome, granulomatosis with polyaginitis, that is Wagner's, essential mixed cryoglobulinemia, IgA vasculitis, that is Hennes-Skolnin purpura, polyarthritis nodosa, or giant cell arthritis. So, these are the common primary vasculitic neuropathies, that is macroscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, that is Creutzfeldt-Strauss syndrome, granulomatosis with polyaginitis, that is Wagner's, essential mixed cryoglobulinemia, IgA associated vasculitis, that is Hennes-Skolnin purpura, polyarthritis nodosa, and giant cell arthritis. Out of this, giant cell is associated with large vessels, vasculitis, polyarthritis with medium and small vessels, polyarthritis, microscopic polyangiitis, essential eosinophilic granulomatosis with polyaginitis, and Wagner's are a small to medium vessels vasculitis, whereas essential mixed cryoglobulinemia and IgA associated vasculitis are small vessels vasculitis. Then approach to Plexopathies. We will make a diagram of brachial plexus. How we will make a diagram of brachial plexus, and then we'll discuss the lesions of the brachial plexopathies. Here is the 4 blocks: C1, C5, C6, C7 and T1. And we have to add 3 Ys, then 2 turns of E's, that is inverted E, and then makes X here. This will lead to the formation of brachial plexus. These are the different nerves. These are ulnar nerves, medial nerve, musculocutaneous nerves. These are axillary and radial nerves. This is the root, trunk, cord and nerves. Root include from C5, C6, C7, C8 and T1, from the 3 blocks like C5, C6, C7 and T1. Then trunk include upper, middle and lower trunk. Cords include lateral, medial, lateral, posterior and medial. And these are the nerves like axillary nerves, radial nerves, ulnar nerve, medial nerve and musculocutaneous nerves. And these are the different branches from it, that is lateral cutaneous nerves of the forearm from musculocutaneous. Then from upper part of the trunk includes subscapular and dorsal scapular nerve. Long thoracic from C5, C6 and 7. From medial cords include medial cutaneous nerves of the arm and medial cutaneous nerves of the forearm. So these are the different nerves from the brachial plexus. Then pattern of brachial plexopathies. If there is upper trunk and lateral cord injuries, this patient will present with hyposthesia or paresthesia in C5 and C6 dermatome, that is lateral upper arm, forearm and thumb. They will have proximal weakness in suprascapular nerves, leading to supraspinatus and infraspinatus muscle weakness. Weakness with the involvement of axillary nerves will lead to deltoid weakness. Musculocutaneous nerve involvement will lead to biceps brachii and brachialis weakness. Radial nerve involvement will lead to brachioradialis weakness. Arms hang at the side and internally rotated at the humerus, and forearm pronated. That is called as Erb's palsy, can occur with the involvement of upper trunk and lateral cord injuries. It has reduced biceps and brachioradialis reflex. The causes for these injuries or upper trunk and lateral cords include trauma, that is birth trauma, fall or penetrating injuries, compressions like Roquet's palsy, idiopathic like neurogenic amyotrophy, inflammations like MADSAM, radiation plexitis and hereditary. So these are the different causes that can lead to injuries of upper trunk and lateral cords of the brachial plexus. Then If the patient has the injuries of lower trunk and medial cords, this patient will present with hyposthesia or paresthesia and C8T1 dermatome. Distal weakness in ulnar nerve will lead to finger abduction and adduction weakness, as well as medial fingers and wrist weakness. Median nerve will lead to thumb abduction weakness. This patient will have claw hands or clumpic palsies. The causes include trauma, idiopathic like Parsonage-Turner syndrome, compressions like thoracic outlet syndrome, inflammations like MADSAM can lead to neoplastic invasions like Pancoast tumor and hereditary. So these are the different causes of lower trunk or medial cord injuries of the brachial plexus. Let us discuss a clinical case. A 36-year-old right-handed male developed fluctuating pain and numbness in his medial hands and distal forearm 1 decade ago. Several years ago, he noted decreased sensation in his digit 4 and 5 of the left hand. He denied localized or radicular neck pain, and there was no rash, fever, or change in weight. Examination shows intact strength proximally and distally in bilateral upper extremities. Sensory examination revealed decrement to cold temperature were D4, D5 and medial arms and medial forearms and left greater than right. So this patient has presentation in the medial palms and medial forearm. So what is most likely diagnosis with this history? Whether this is a ulnar neuropathies, whether the patient has C8 radiculopathy, whether this is a thoracic outlet syndrome, whether and herpes zoster infections or upper trunk of the brachial plexus. So this is a thoracic outlet syndrome. As the patient presents with these injuries to medial palms and medial forearm, these are commonly involved, the medial cords are commonly involved with thoracic outlet syndrome. Here, these are the medial cords and these are commonly involved in the thoracic outlet syndrome. These are medial cords or lower cords involvement. Then radiculopathies. Let us discuss another clinical case to understand the radiculopathies. A 45-year-old male with history of pre-diabetes, hypertension and idiopathic small fibers polyneuropathies presented with months of left-sided neck pain. This pain was radiating to left shoulder and upper arm. Pain is graded 4 out of 10. Can worsen to 10 out of 10 with turning his head. She has baseline tingling and numbness in his bilateral arm that is attributable to a small fiber neuropathies. He denies bowel and bladder dysfunctions, trouble with speech and swallowing, or issues with weakness in his lower extremities. He has baseline tingling and numbness in bilateral leg because of the small fibers neuropathies. On examination, he has mild weakness of his left infraspinatus and supraspinatus muscles. A strength testing is otherwise normal. Sensation is normal to cool temperatures and pain throughout the arm. So, what is the most likely diagnosis based on the history and physical examination? Whether it is a diabetic amyotrophy, whether it's a multifocal motor neuropathies, whether it's cervical radiculopathies, herpes zoster or vasculitic neuropathies. It is a case of cervical radiculopathies and the patient has pain over the cervical. On turning the head, the patient presents with pain with the involvement of upper trunks of the brachial plexus. It is most commonly involved with cervical radiculopathies. Then in the cervical region, the nerve roots, the nerve emerges above the vertebra of the same numerical origins. That is, C1 emerges, C5 emerges above the C5, C6 above the C6, C7 above the C7, and C8 above the T1, T1 above the T2. And disc disease results in root compressions at the level of herniation, that is, C7 injuries will lead to C6, C7. That is, if this C7 is compressed, the symptom present with the C7 associated motor or sensory symptoms, means the disease is at the level of C6 and C7. Whereas in the lumbar region, root emerges below the vertebra of same numerical origin. That is, L1 emerges above the L1, L2 below the vertebra of same numerical origin, that is L2 below the L2, L3 below the L3, L4 below the L4, L5 below the L5, and S1, that is below the S1. And disc disease result in root compression below the level of herniations. That if the patient has the symptoms of L4, then L4 and L5 vertebral diseases will lead to the symptoms of L4. Whereas in the patient with cervical, if the patient had C6 symptoms, then C6, C7 disc disease will lead to the involvement of C7 symptoms. If in the patient with L4 symptoms, L4 and L5 compressions, disc compressions will lead to L4 symptoms. Then structural radiculopathies, soft herniations, that is tear of annulus fibrous and herniation of nucleus pulposa is common with age less than 40. A spondylosis with osteoarthritis in a spine joints and herniations at the age of greater than 50 years. Majority of radiculopathies occur in lumbar regions, and minority of radiculopathies occur in the cervical region, most common being C7, and majority of radiculopathies occur in the lumbar regions in the L4, L5 or L5, H1 region in 95% of the cases. Then treatment of structural radiculopathies, majority in lumbar regions recover with conservative treatment like physical therapy and exercise, epidural steroids injections like pain reliefs, but no impact on neurological functions, on likelihood of the surgery. Better outcome for root effacement or displacement or nerve roots compressions. So, epidural steroid injections is effective for root effacement or displacement. Indications for surgery include progressive weakness or intractable pain despite conservative therapies. Other causes of radiculopathies include infections like Lyme's disease, which leads to painful polyradiculitis, CMV, lumbosacral radiculopathies as in HIV associated, cytomegalovirus infections, varicella zoster infections, which lead to radiculopathy in thoracic regions, more prominent than lumbosacral, with cranial involvement more common than cervical involvement. Then syphilis can also lead to radiculopathies, inflammatory disorder like sarcoidosis, AIDP or CIDP, metabolic causes like diabetes, neoplastic disorders like solid tumors, leukemia or lymphoma. These are the other causes of radiculopathies. Thank you. This was all about radiculopathies, how we will approach these radiculopathies.